Sure. All content in this educational overview is based on the work of Dr. Mohammed Al-Nagi Mohammed. Welcome back to the deep dive. Today, we're really getting under the skin of a huge topic for the MRCGP AKT exam, and that is, of course, dermatology. Our mission is to take this incredibly dense, high-yield clinical material and basically turn it into something you can absorb, something you can really use.
That's the plan. We're essentially converting a clinical compendium into, high detail audio revision notes. Because for this exam, it's not enough to just know the name of a condition. You have to know the NICE guidelines, the BNF criteria, the specific management steps.
Exactly. It's about that foundational knowledge. We know you're trying to get a lot of information in your head quickly but thoroughly. So we're going to slow it down, cover every critical detail from our source, and really make those connections.
Right. So let's jump in. Part one is all about eczema variants and some of those less common blistering conditions that can trip people up.
Okay, let's do it. First up, pumpholics.
Right, palmopholicus. Or sometimes it's called dyshidrotic eczema, which can be a bit confusing. The first thing to lock down is its location. This isn't your typical all-over-the-body eczema.
So it's very specific.
Very specific. It affects the hands, which we call chiropompholics, and the feet, which is pedipompholics.
Okay, so if a patient comes in, what in their history is going to make me think pumpholics specifically and not just a flare of their usual atopic eczema?
You want to be listening for the triggers, the precipitating factors. The big ones are environmental. Think humidity, think high temperatures.
So summer weather, that sort of thing.
Exactly. Sweating is a massive trigger. That's actually where the old name dyshidrotic came from, this idea. It was a disorder of the sweat ducts. We know now it's not that simple, but the link to sweating is definitely real.
And the look of it, the morphology is pretty distinct too, right?
Oh, absolutely. You're looking for small, deep-seated blisters, and they're specifically on the palms of the hands and the soles of the feet.
Not the backs of the hands.
Generally not. It's on those palmar and plantar surfaces. And symptom-wise, it's not just a mild itch. The pruritus is described as intense, and it often comes with a really significant burning sensation. It can be incredibly distressing for the patient.
You mentioned it's a two-stage process. What happens after those blisters appear?
Well, that's the thing. They don't just stay there. After a while, those blisters will either burst or just dry out, and that kicks off the second phase.
Which
Extreme dryness. The skin gets flaky and it starts to crack, which can be just as painful as the blisters. You can get these nasty fissures.
Okay, so it sounds awful. Management needs to be pretty targeted. The source lays out a three-pronged strategy.
It does. Step one is immediate relief. You've got to deal with that burning and itching. Simple, cool compresses work wonders here.
Just to bring that inflammation down.
Exactly. Then step two is barrier repair. Like with any eczema, you need heaps of emollients, especially in that dry, cracking phase. And finally, to get the underlying inflammation under control, you bring in the topical steroids. So it's a combination. Soothe, repair, and suppress.
Perfect. Let's move on to a condition that really hammers home our theme for today, which is the skin as a window to internal disease. Porphyria cutanea tarda, or PCT.
Ah, yes, PCT. This is a classic example of dermatology pointing you directly towards a systemic problem. In this case, it's all about the liver.
It's the most common hepatic porphyria, I believe.
It is. And the etiology, the cause, is really interesting because it's kind of twofold. In some people, it's an inherited defect in an enzyme called uroporphyrinogen decarboxylase.
Which is part of the heme synthesis pathway.
Right. But, and this is what you'll see more often clinically, it can be acquired. It happens secondary to damage to the hepatocytes, to the liver cells themselves.
So in the patient's history, what kind of damage are we looking for? What are the red flags?
You're hunting for anything that puts stress on the liver. The big ones are significant alcohol excess, chronic viral infections like hepatitis C, and also certain medications, particularly estrogen use.
And the key features. We're looking for a classic triad, with the photosensitive rash being the most common sign.
That's the hallmark for sure. The patient presents with this incredible skin fragility and blistering on sun-exposed areas. So the face, and especially the back, the dorsal aspect of the hands, minor bumps can cause huge erosions.
And what are the other two parts of that triad?
You get hypertrichosis, which is excessive hair growth, often on the face, and you get hyperpigmentation, so the skin can look a bit dusky or mottled. If you see blistering photosensitivity plus hair growth and pigmentation, PCT has to be high on your differential list.
Now, for investigations, there's a really specific high-yield test involving urine.
Yes, there is. So you can check for elevated uroporphyrinogen in the urine, but the classic test, the one they love for exams, is using a Wood's lamp.
And what do you see?
The urine shows a distinct pink fluorescence under the UV light because of all the porphyrins. It's a very memorable diagnostic clue.
We also need to check serum iron ferritin. Why is that so important?
Because iron plays a direct role in the disease process. High iron stores make it all worse. So the ferritin level isn't just for diagnosis, it actually dictates your management strategy.
Which brings us to treatment. We've got chloroquine and venesection. When do we choose venesection?
Venesection, which is basically therapeutic blood removal to get iron levels down, is the preferred treatment if that serum iron ferritin is above 600 nmol.
So the lab value directly triggers the intervention.
Exactly. It's a classic AKT style question. Get the iron down and you slow the whole process down.
Great. Let's move into part 2, looking at vascular marks, and then the really critical topic of purpura.
Okay, let's start with port wine stains, or PWS.
Right. So these are those unilateral, deep red or purple marks. I think the most important thing to know here is their natural history, how they behave over time.
You've hit the nail on the head. This is the crucial point for counseling patients. Port wine stains are permanent. They do not spontaneously resolve.
Which is the big difference between them and, say, a salmon patch or a strawberry hemangioma.
The biggest difference. Not only do they not go away, they actually tend to change over a lifetime. They often get darker, going from pink to a deep purple, and they can become raised and even a bit nodular over time.
So what are the options we can offer?
Well, in the short term, cosmetic camouflage can be very effective. For a more permanent solution, you're looking at laser therapy.
And that's not a one-and-done treatment, is it?
Not at all. You have to be very clear with patients that it requires multiple sessions to get a good result.
Okay, let's contrast that with the very common, very benign salmon patches, also known as stork marks.
Right. And these are incredibly common. You see them in about half of all newborns, so they cause a lot of parental anxiety. They just look like pink, blotchy marks.
And they tend to appear in specific places.
Yes, usually midline. So the forehead, eyelids, and the nape of the neck. And the key piece of information for parents is reassurance.
Because they fade.
They almost always fade over a few months as the baby grows. The one exception is that marks on the nape of the neck, the stork bites, can sometimes persist, but they're usually covered by hair.
Okay, now we're shifting gears to something much more serious. Purpura. This is a true dermatological emergency.
It absolutely is. Let's define it first. Purpura is bleeding into the skin. The result is a non-blanching rash.
Meaning, if you press a glass on it, the redness doesn't disappear.
Exactly. And petechiae are just the tiny version of that, 1 to 2 millimeters. The mechanism is usually a problem with platelets being too low or a bleeding disorder where the blood just can't clot properly at the microvascular level.
So when we see this, especially in a child, alarm bells should be ringing.
Loudly. The protocol is clear. Any child with a new purpuric rash gets an immediate admission for investigation. No exceptions.
Because we're trying to rule out some really scary things.
We are. The number one concern is meningococcal septicemia. But we're also thinking about things like acute lymphoblastic leukemia.
And there's a critical management step that has to happen before the hospital transfer.
Yes, and this is life-saving. If you suspect meningococcal septicemia, the child gets parenteral antibiotics right then and there before they even get in the ambulance. That single step can make all the difference.
Let's break down the causes, because the list is quite different for children versus adults. For a child with purpura, what's on your differential?
Okay, for a child, number 1, meningococcal septicemia, then ALL, other congenital bleeding disorders, ITP, Henoch-Schönlein purpura, and you always have to consider non-accidental injury.
And for adults, the picture changes a bit.
It does. ITP is still on the list. But you're thinking more about bone marrow failure from leukemias or metastases. You also see senile purpura in the elderly. Drugs are a huge cause quinine, some antiepileptics, antithrombotics, and don't forget severe nutritional deficiencies like B12 or vitamin C.
There's one important caveat, though, about petechia caused by high pressure.
Yes, this is a good one to know. Someone who's had a severe coughing fit or has been vomiting violently can get raised superior vena cava pressure.
And that can cause little spots.
Exactly. You might see some petechiae around the eyes or on the neck, but that's a mechanical thing. It's not true purpura, which implies a systemic problem with clotting. It's an important distinction to avoid unnecessary panic.